I think for this patient, in keeping in completeness, for the sake of completeness and full discussion about this case, so this is a young patient, received FCR, achieved a complete remission, is MRD positive. So we do know that their likelihood to relapse is, he's going to relapse. He's probably going to have a longer progression-free survival than perhaps, for sure, patients who have an unmutated V gene and are MRD positive. But the fact that he's MRD positive puts him in a higher risk for progression, and I think we should probably touch on maintenance strategies, because there are data that support maintenance for this type of patient. There are data for lenalidomide as a maintenance strategy, and CD20 antibodies, both rituximab and ofatumumab. Those trials, 3 randomized trials that are phase 3 trials looking at progression-free survival, have clearly demonstrated improvement in progression-free survival for patients who have received a maintenance therapy, whether it's lenalidomide monotherapy or CD20 antibody monotherapy, with a hazard ratio of 0.4 to 0.5 for progression-free survival. None of those trials have shown improvement in overall survival, and all treatments have been associated with some increased risk for toxicity, whether it's lenalidomide or CD20 antibody. There are immune effects for those strategies, and increased risk for infection, and there clearly is an increase in infectious events for patients who are receiving the maintenance therapy. I think I should comment, and maybe I'll ask Matt to comment also. We don't typically do maintenance therapy for patients, whether it's lenalidomide or CD20 antibody. There are a couple of instances where I have given CD20 maintenance, and that's particularly in patients who've been in remission and have had issues with autoimmune phenomena. So I will put patients who are in remission, who have had autoimmunity, recurrent particularly autoimmunity, where I'll put them on an extended course of maintenance CD20 antibody, whether it's rituximab or ofatumumab. And I've found that will reduce the risk for recurrent autoimmune phenomena and perhaps extends progression-free survival. But maybe you can comment on what your thoughts are on maintenance.
Yeah, we don't typically use maintenance therapies for CLL patients. I think sometimes it's tempting to extrapolate from other indolent non-Hodgkin lymphomas where there may be more benefits to, for example, rituximab maintenance. But unfortunately, the data in CLL don't support an overall survival benefit. And even if there are some PFS benefits, I think it's always important to think about the patient population that's been studied. And some of the randomized studies you alluded to were for patients who had been through 2 or even 3 prior lines of chemoimmunotherapy and then were put on a CD20 antibody. And these are just not patients that we're seeing a lot now. We're typically treating these patients with novel agents, and I think that's probably a better way to go after chemoimmunotherapy.
Thank you, Matt. Thank you, Dr. Bagg, Dr. Davids, Dr. Jan, for your thoughtful case presentations and a very lively, informative discussion. To our viewing audience, thank you for joining us for this targeted oncology virtual tumor board presentation. We hope today's discussion was a valuable use of your time and that you acquired some practical knowledge that you can take back to your clinic.